If we're ready, I would like to see a thumbs up from Stefan and Jasmine. Okay.
Yeah, let's do it.
Great. Turning over to you, Stefan.
Awesome. Thank you, everyone, for joining and taking the time. Greetings wherever you are in the world. And looking for my piece here. So my name is Stefan Wallace, and I wear many hats, including serving as the Director of the Office of Community Engagement with the UW Fred Hutch Cfar here in Seattle. And we're here today to really talk about what we've been doing regarding community engagement here recently, to get some perspective from you all about priorities in the community and opportunities for partnership, as well as to get some perspective about how we're going to move forward with the Cfar and our 5-year renewal. But before I jump into that, I want to give quickly an opportunity for all of my colleagues who are speaking in this session today to briefly introduce themselves, and then we can transition. And please feel free to interact via the chat feature, including sharing your name, your pronoun, where you're from. That would be important for this conversation as well. Next slide.
Sorry, I got a little stuck here.
No worries.
Okay, there we go.
So many people may be aware that the UW Fred Hutch Cfar is part of a national network of Cfars that really bring together multidisciplinary groups, including academic researchers, community advocates, and public health practitioners who are doing HIV-related work in order to synergize efforts, ultimately with the goal of responding to the HIV epidemic. So our Cfar is one of many Cfars, a part of this initiative, and this is funded by the National Institutes of Health. And we are not necessarily a research center in the traditional sense of the word, where many people may be familiar with the NIH or Division of AIDS funded clinical trials networks, like the HBTN as an example. I see my colleagues here. But we do provide funding, training, capacity building, and really opportunity for collaboration across disciplines in order to generate research, to generate information and knowledge, and really as well as interventions that will help respond to the HIV epidemic. So quite a bit of history with our Cfar, 34 years and running, with strong local and international partnerships, and with over 700 members. So this is truly a massive endeavor with lots of players and lots of coordination, both here locally and across the pond. Next slide. So really briefly, there have been quite a few efforts, but just in recent history, there was a community-based organization needs assessment that was conducted, where we assessed the CBO's capacity to engage in HIV research, and really wanted to look at what were the barriers, as well as what were potential facilitators for CBOs to really engage as partners in this process. And the report of this, I believe, was shared out with you all via the agenda. So feel free to dive further into that at your leisure. Of course, there is an opportunity to engage in other work regarding community engagement, including the Global Scientific Advisory Board survey, which really looked at how to better collaborate with folks and teams and advocates, et cetera, across the pond and international settings as well. And then most recently was a community engagement needs assessment. And what facilitated this needs assessment was really thinking about how we can continue to evolve and enhance the ways that we engage and partner with communities. And I believe the report for this was also shared with the meeting materials. So please also feel free to dive into that more at your leisure. But from all of these opportunities, and certainly from the interest that we have, both here in the Cfar as well as for many of our partners who are connected to us, we're constantly looking at ways to better partner, to better collaborate. And so some of the key opportunities include capacity building and training and funding to advance community priorities, ensuring that we have representative leadership across communities, and having folks who reflect the communities as part of our partnership pool. And of course, mobilizing and enhancing our infrastructure to ensure that equity, diversity, inclusion, and community engagement approaches are scaled. Next slide, Jasmine. So for the CE activities, we've partnered with our folks internally to support the principles course that many folks here may be familiar with. And I know some folks here have supported through field trips, CBO field trips, as well as participating as participants. Meet the Researcher events, which were really opportunities for communities to engage researchers about their research and to ask critical questions about applicability and scale, et cetera. And it also provided researchers an opportunity to get more comfortable engaging communities about the research they were conducting. We increased funding award amount and frequency for the Mentored International Investigator Award. And we're proposing a new Community Investigator Award program, which would help to build capacity for community focused researchers as well as academic partners to work together to respond to community needs. So the representative leadership component, the community consultative group that, which is some of the members are represented here via their introductions, and promotion of international investigators to core leadership roles, including the development core. Conducting consultations with various cores, including the developmental core on awards programs. The symposium, which has been a major, an amazing program, and ensuring that we are supporting researchers to communicate and disseminate their research into communities further by the adoption of a community slide, which really distills their research down to what are the key areas that are of priority for many communities. And of course, collaboration on the Cfar seminar. And what many people may have read in the materials that you were sent, if you were not already aware, is that the UW Fred Hutch Cfar Community Advisory Board have been retired. And in its place, we developed the Office of Community Engagement. And that information has also been sent out. So I think we can move to the next slide. Okay. So we are at the place in the agenda, and I just wanted to check to see if he has joined yet. Doesn't look like he has. So we are at the place in the agenda now where we are going to stop talking to you and start listening. And to do that, we have developed some questions to elicit some conversation and some discussion. So I'll ask the first question, and this is directed to our community members and community partners here. How do you define community engagement, and how can the Cfar better engage you in the future? And what are some ways that Cfar can better collaborate with your organization? And for this part of the conversation, please feel free to respond either in the chat, or you can, I believe you can unmute and respond in that way as well. I'll repeat the question for folks who may be on the phone. How do you define community engagement, and how can Cfar better engage you in the future? What are some ways that Cfar can better collaborate with your organization? Thanks for that, Susan.
Yeah, feel free to raise your hand if you want to make a comment or put your comment in the chat. Also seeing that Stephen just joined, Stefan.
Awesome, thanks.
And if folks have any examples of interactions with the Cfar in the past, what's been helpful, what's not been as helpful, that's nice to hear too.
The beautiful thing about the folks that are largely here is that I know many of them. So I can also reach out and touch some folks if they to get this conversation started as well.
Just stop the projection momentarily so folks can see one another's faces.
Sure.
At this phase, yeah.
All right, I'm going to reach out and touch Alejandra. You knew it was coming.
Oh my God. Yeah, so for us, you know, like I'm from Entre Hermanos, you know, we're the only LGBTQ Latino agency in Seattle. And for us, community engagement looks more than a family event, right? Like we bring people to Entre Hermanos. Like before the pandemic, we used to have community forums. We used to have movie nights the first Wednesday of every month. But since the pandemic started, we haven't been able to have at least that type of indoor events. So we've been having outdoor events. The last event we had was on April 8th. It was a spring fair in collaboration with El Centro de la Raza, in which we offered vaccinations, we offered Orca Lift enrollment. We also had a concert from Richard O'Neill, I believe that's the last name of, he plays the violin. And we had more people than expected. We had at least 70 attendants. And we are planning our next community event to be, well, it's gonna be our fundraiser on May 7th. It's gonna be our Cinco de Mayo brunch. But we are also working with Swedish, for example, on having a community clinic that's still in the works. And we are going to have our summer fair, still trying to decide when that is happening. But for us, the best way to audit our community is in Spanish, definitely, because we serve most people that speak Spanish. And for us, it will be helpful to receive like training or information in Spanish that clients would be interested on, right? And using like a type of language that is not very like professional, because people sometimes don't understand, right, the words. And it's something very easy to access to. And yeah, thank you.
No worries. Thank you for that. Anyone else? I'm going to scroll through to make sure I'm not missing anyone.
Can I ask a question?
Sure. Is that Roberto?
Hi, good morning. Alejandra. Hola.
Hola,
When-
Roberto.
When you talk about working with Swedish and Centro de la Raza, how did that engagement happen? Like between you and Swedish and you and Centro, how that happened? How did that feel that it was two-way or respectful to you and your organization?
Well, for Swedish, they reached out to us with the idea of having a prep clinic on site. That unfortunately didn't work. So the process we're going through right now is we refer people to them. It's just a bit of a long process because the person has to apply to financial assistance before going to the Swedish clinic, right? And so that makes things a little different because well, I mean, if the person has Medicaid or Medicare, they don't have to access to they don't have to apply for financial assistance. But most of the community we serve are undocumented, right? So I told him Medicaid is not a big option, like not really happening. And so we're working with them on having this spring clinic, and it's going to be like easier to access. I hope I'm going to have a meeting, I believe, in a couple of weeks. And with El Centro, we worked with them in the past. We, like when I was a volunteer at Entre Hermanos, we used to work together, to have the Dia de Muertos altar and all those things. And our director of development, Enrique Maimi, he used to work for El Centro. So that's how we have the connection with them. But it's been working so far with El Centro. And they have been really kind, and they have not charged us for the room. We use the Roberto Maestas big, no, I'm sorry, not, it's the Centilla Center that is in the Roberto Maestas Plaza.
Thank you.
There's a question in the chat from Ulysses. Does the Cfar have a faith and spirituality research collaborative in place? That would be the best way to connect with communities I serve.
We don't have that, but I wonder how that would be helpful, how that would work. You see that in other institutions? And
I also want to acknowledge that there is a cross Cfar faith initiative that many folks are connected to. Actually, Jimmy Gibbs
Yes.
is connected to that as well.
Thank you. I was going to just say that, Stefan, thank you. And I can announce always that Vanderbilt University has picked that up from UAB as of yesterday. So you will hear a lot more from that Inter-CFAR working group soon. Thanks.
No worries. Thanks for that, Jimmy. I know, just for everyone's reference, that the folks working in that initiative more closely have done things in terms of presentations at conferences, as well as symposia, really focused on bringing multiple faith traditions together, diverse faith traditions together to think about how to respond to HIV issues in communities across the country. Great question. Thanks for flagging that, Susan. Always good to see you, Jimmy.
You as well.
All right, I'm gonna turn this over to one of my colleagues, Stephen Sawyer, to briefly introduce himself and to ask the second question.
All righty. Thank you, Dr. Wallace. Stephen Sawyer, the Executive Director of POCAN, and part of our community group. So the next question really is, how has COVID-19 affected HIV prevention and education efforts? And has your organization or a community implemented any new prevention strategies during the pandemic? And if so, do you foresee any additional changes or long-lasting effects due to the pandemic? So we just want to have a discussion around that.
Hi, everyone. I'm Paul Park from Lifelong. I'm happy to start. I was actually gathering my thoughts on the first question, so I'm happy to share my thoughts on that first question as well as this second one on COVID-19. So just to contextualize, I'm new to Cfar. This is my first meeting. I'm actually relatively new to Lifelong, having joined about 9 months ago. So perhaps some of these items I'm going to suggest are already happening, so I'm here mostly to learn, but just want to share some of my initial thoughts. So first, around community engagement, we define community engagement in many ways. One of the key components is around harm reduction and meeting the clients where they are. So that obviously requires us to really have a finger on the pulse of what's happening on the ground, what's happening in their day-to-day lives, their communities, et cetera. And then I'll add that, in terms of our role of community engagement, a large part of that is around innovative implementation around the social determinants of health. So I think, especially when working with researchers, really focusing on, how can our implementation approaches be improved, and kind of begs the question of, implementation science questions. The third piece around community engagement is, as mentioned, in trying to get the finger on the pulse, we work on items like community advisory boards, surveys, focus groups, and these are, I've quickly learned since joining Lifelong, these are frequently part of our contractual obligations with our government partners, which is great. But one thing I've observed is the qualitative analysis, especially when we receive this information, is frequently lacking. And so in terms of thinking of the question, how can we work more collaboratively with the University of Washington, I do think that qualitative analysis component is key, because we're constantly trying to get the client voice, making sure that we understand a broad range of thematic inputs that are being provided, and how to synthesize all that qualitative information is important. On that note, I would also say that the data collection, when doing innovative implementation in the community, I think, I imagine a lot of community-based organizations can, that this may resonate with them. Kind of the last thing on our minds when we're trying to execute this by a certain deadline and feel that pressure is, do we have the data collection tools in place so that we can actually analyze what we just did to show that it was effective? Obviously, researchers know that that takes a lot of very careful planning and time, but just given the limited bandwidth and staffing, it's not easily done. And so having that type of support early on in the process as we're planning the innovation and the implementation, I think that type of focus on data collection tools would be really helpful. And then, as I mentioned, just analysis, whether it's qualitative or quantitative, helping us think of how to see if our outreach and our engagement projects are actually working. And part of that is understanding both the implementation outcomes, but also the downstream clinical outcomes. I find that the downstream clinical outcomes, just the way our software programs are set up, a lot of the software packages we use are government required software programs that will enter data, but and it's fair that we don't necessarily have as much input or control on like which variables we want to be routinely collecting, and so that makes it challenging. So I think having research minds supporting us on how to connect the dots between we may be implementing at a social determinants of health level, but potentially this is impacting the clinical outcomes, which we don't necessarily have that data. So linking our limited database to the downstream clinical outcomes, potentially at University of Washington Health System, I think could also be really helpful. And then another piece that comes to mind, and in my early observation at Lifelong, is our leadership. So I represent I'm more or less the research representative. Most of my colleagues don't have technical research experience or have worked with researchers, et cetera. And so I think I would love our directors, our leadership at Lifelong to be able to have that research lens and just understand what it means to think about research questions. I don't expect them to, dive deep into analysis per se, but just to be able to understand the proper approach to framing and thinking about research questions would be, I think that type of basic training would be super helpful. And then the last thing I'll say on this before jumping to COVID is, I think it seems like just seeing the people in this room, Cfar is at a great position to bring collaboration between community-based organizations. I'm familiar with many of the organizations represented here and would love to collaborate with many of you. I think that would be amazing. And I think, this forum is a great opportunity for that. Lastly, so for COVID-19, so we've been adding vaccination education to most of our routine encounters with clients. So this is a topic that we did a training on to our case managers so that they feel comfortable talking about and trying to promote COVID-19 vaccine. Again, we have some very minor data collection systems in place to make sure we're documenting and being able to assess how successful this campaign is. We've also integrated our HIV counseling and testing initiatives that is community-based. We've combined COVID-19 rapid tests into that. So we've actually been able to integrate. And I think that experience has taught us, the need to really use the HIV testing and counseling point as an opportunity for more horizontal growth. So we've already added other STI testing, again, rapid testing, point of care testing. We've now added COVID-19 testing. So I think this horizontal integration and building upon the structure that HIV has provided is a really great opportunity. So that, the kind of the next step we're thinking about is integrating, blood pressure checks, glucose meter testing. So looking at other chronic conditions that people living with HIV are suffering from, do have a high burden of disease, and seeing how we can integrate horizontally. I've spoken a lot, so I'll stop there, but thank you for this, bringing all of us together.
Thank you, Paul. I think that's great information. Is there anyone else?
Yeah, for us, when the pandemic started, we started to work remotely, and we were still offering testing, HIV and STI testing by appointment only, and our numbers went down. Of course, like people were scared. I still leave the house, come here, but like even though the numbers went down, like we never reached like 0 tests, right? It was something like, you know, like 2-3 tests a month, which wasn't ideal, but it was something. And then we decided to reopen for walk-ins in June last year, and our numbers have been very steadily. We are testing about 24 people a week for HIV and STI testing, and we're very happy about it. And we are planning to work with the hepatitis C project. They have nurses from Country Doctor there, and they might be able to start offering STI treatment there. So that way we will become a little bit of a one-stop clinic, because, you know, like it's very hard for clients to call here, get the results, go to a like an after hours clinic. And then the problem that we've had with after hours clinic is that they want to retest the clients again, and then the clients get charged, even though like we've sent the public health results. So that's been a little bit challenging. But, and for education, we've also been working with the OH, making videos in different indigenous languages for the last 2 years. And the same, like lifelong, we have no way to like measure how many people we've been able to reach, but we feel we've been successful because people are coming to us. So I think it's working. Thank you.
Awesome. Thank you. Anyone else want to tell us about the effects of COVID-19 on their prevention or education efforts?
If I may, sorry, I don't know if anybody has said this, but I will add this. Burnout, I don't know if anybody has mentioned that, but as far as staff, it's people in the workforce, it's getting pretty rough for folks staying in their jobs, and then how they function within their role, power dynamics, wherever they are. So if we can find some kind of way to provide staff support for people who are on programs, on contracts, because they need it. And sometimes we don't hear from them what they need because there's been a lot of shutdown. And so I think a lot of staff need support if we can find a way.
Awesome. That's really good.
Connie, I see you have your hand raised.
Well, this is really, really helpful feedback. I guess a couple of, first of all, I love specificity in terms of any kind of, it'd be really helpful to hear, like, as you were talking, Paul, I was thinking, there's such a large cohort of like MPH students, many of whom are looking for capstones, and I've heard you, and I think also Alejandra touched on this, is just the need for help with maybe design and analysis of monitoring and evaluation. So at some point it'd be helpful to just know has anyone reached out to you? Have you reached out and had any success or not success in trying to engage like EPI students, for an example, to help with designing this, would be mentored by a faculty member. And so that would be one thought. And then I guess secondly, I'm just curious, is there a forum for all of you to meet at? I mean, is this unusual, or do you all meet in other contexts? And if so, could you describe that a little bit more?
Yeah, I'm happy to take a first stab at those questions. So with EPI students, we have thought of that. We know that that's a priority, and that's an opportunity to collaborate and especially work within our tight budgets. I think, I haven't necessarily felt comfortable that we have a specific project kind of packaged up and ready to deliver to a student. maybe, you know, we're thinking about it incorrectly and we should just bring on a faculty or student to help us, you know, package up a project. We have been approached by Seattle University, and this was more to work with their classes to do really to provide them data sets so that these are undergraduate students to learn about how to do basic data analysis, answer simple questions. And that actually has been helpful. It's been pretty basic, but it's been helpful for us. So that's been our engagement so far, but I absolutely agree. I think working with especially graduate level students that are mentored by faculty, that would be great. We just haven't gotten to that point, but we're certainly happy to start that conversation. Again, this is my first meeting here, so I think you know, this encourages me to take that on more. And I think in terms of how a lot of the CBOs work together, there are different forums like coalitions that are focused on specific social determinants of health, such as housing, has several of them. Then there's specific social service organization coalitions and alliances. And so we do have opportunity to collaborate, but a lot of those meetings focus more at, you know, high level policy issues. Sometimes you get into the projects, but I would say research and evaluation, those are I wouldn't say those are the strong points in terms of, you know, topics of conversation. So I think this group is quite unique in that way.
Thanks, Paul. Were you going to say something? Not to put you on the spot, Wakefield.
We don't have enough hours for me to say all the things I'm thinking. First of all, I'm sorry I joined late. And if there was an acknowledgement that we're on Coast Salish, Duwamish land, I want to say I missed it, and I just want to acknowledge that for myself and for everyone else if we didn't have one. But it strikes me, having only had time to glance at the report, that many of the CBOs that were part of the survey have had turnovers in leadership and a great number of turnovers in staff. And the kinds of things that are available that the Cfar explored and can offer, there isn't another forum that I know of in this city where people come together around HIV issues or come together to do what Paul has suggested, and that is look at how do we link the opportunity when somebody comes in because of their concern around COVID or diabetes or any other health-seeking behavior to make sure they're getting HIV information and accurate HIV information. And I also think that the Cfar has been historically very important in educating providers who are both in HIV and not in HIV. And so they're, you know, doing grand rounds or putting information out. I recently talked to a provider who only learned about PrEP when he read through what happened when he referred somebody for PEP. And, you know, the materials were developed a long time ago, so we don't think about them. But when we get to the future, I'll have more to say about outreach, but I don't think there's a forum for CBOs. And I also think, as I heard Paul acknowledge, there are lots of people that their health-seeking behavior doesn't connect them with a number of the existing CBOs that are HIV focused.
Thank you. There's anything else on COVID-19 or the previous question anyone want to answer or respond to? In a few more minutes. And if not, I'm going to pass it to my next colleague, Rahel, and she'll pose the next couple of questions and introduce herself.
I noticed that Joanne raised her hand as well.
I was just going to ask, Michael made a comment about the salon that had previously been run by Public Health Seattle King County back in the era when I was there. And so does that not exist anymore? Is that something that people would find helpful? Should we think about waking it up again in some version?
My mentioning of it, by the way, was not a condoning of it, but it was a way that we came together, usually around a topic related to HIV or related to harm reduction, whatever the topic might be. Sometimes it was bringing in some professional staff, like to talk, give a talk, you know, like sometimes it was research related, but we would all get a chance to be in the same room, and they were popular back in the day, and then they started to wane. They still exist in a form of on Zoom. They're not nearly as frequent. They used to be every month. Just to give you more details of that. I don't know what went wrong. I don't know if anyone else, you know, because they used to be well attended and now it seems like not as well attended. And I think still important things are discussed there. You know, we just had a report from the pitch study and stuff like that, which was great to hear because that was directly related to our communities who are affected by HIV.
Just flagging that Brian has some experience with the salon recently. Brian, would you mind sharing your experience?
Sure. Yeah, just I would say, you know, the salon has been going on for my entire time working in HIV in the city, and I hadn't really noticed what you had shared, Michael. Now that you mention it, I do see that the attendance has gone down. I would probably just attribute that to moving from in-person to Zoom meetings online, and would be curious to see what would happen if we moved back to in-person meetings with the salon. But yeah, the topics are always really wonderful. I always learn so much. They're very similar actually to a lot of the presentations. Like, you know, my interactions with the Cfar are primarily through the email that goes out to the listserv with all that great information, the articles, the upcoming events, and so forth. I love getting those emails, but also the just, you know, webinars with researchers presenting on their research, on their science. The salon will do things similar to that, where, you know, they'll have public health come in and present on a particular topic. I believe that salon used to be called the MSM salon, or it was focused primarily on men who have sex with men, but it has shifted since that time. I think there's still kind of a legacy focus on men who have sex with men, but the topics have broadened in recent years as well. So that's a little about my experience with salon.
Thank you, Brian. And for those with whom you have not yet connected, would you introduce yourself and share your role? And
yeah, sure. I'm Brian Minalga. I'm moving so I can maybe come on camera for a second. I'm Brian Minalga, and I work at the Office of HIV/AIDS Network Coordination. I'm based at Fred Hutch here in Seattle. So I've been in the field for about 6 years here. And yeah, we work with the 4 NIH-funded HIV/AIDS clinical trials networks. Thanks.
Thanks so much.
Thanks for that, Brian. Ray has his hand up, and then Roberto.
I was going to say that back in August, I completed NMAX Escalate training. And one of the things that came out of that was myself and 2 of my teammates, we participated. One of the ideas was to come up with a stigma workforce group across the state. And so that is still a part of my plan. I actually have a survey that I'm going to be releasing this week. So while that is open, I'm going to start reaching out to folks about this particular work group. But the reason why, I think we have a lot of things to discuss on multiple different areas, not just clients, but again, staff and changes, systematic changes that need to be made. And so these conversations are going to be leading towards things that we can do across the state together. I think as we worked on the EHE efforts before, I think a lot of the strategies were not cohesive. We had a lot of agencies wanting to work together, but there was no direction to go in. And so these work groups will allow us to be able to focus on things that can happen regionally, but also things that we can work on as a state. So I just wanted to throw that out there. Be prepared to hear from me soon.
That's right. Roberto?
Yeah, I just wanted to follow up on what Ray said and a few other comments in the chat and related to the salons. But I hope as we come out and when we come out of COVID that we can gather and not talk about research and grants. And, it's the burnout and the hard work that we all do that we just need to gather after these 2 or 3 years and just chill and eat food and get to know each other better. And then we'll have another salon to talk about grants and research. But I just hope that we all can come together to do that pretty soon. Just wanted to say that.
The town hall that we're planning is designed to do just that. So I guess we shouldn't call it a town hall because that's sort of misleading, but it's more of a gathering of folks to come together. And I'll be looking forward to seeing everyone participate in the dance contest. So.
Rahel is the sergeant at arms for the dance contest. Don't volunteer. You know Rahel's background, you'll understand that.
And speaking of Rahel, I think you're next up for the questions, Rahel. Thanks, everybody.
So my question is, what are some community-centered approaches to HIV prevention, and what do community healthcare workers need to know to be more successful in working with people living with HIV? So what are community-centered approaches to HIV prevention as you are working with different communities, and what do community healthcare workers need to know to be more successful in working with people and living with HIV?
If I may, one of the things that we did when I worked at Center for Multicultural Health was we had a peer recruiter program. And so this is different from peer navigation. The peer recruiter program, so at Center for Multicultural Health, we had a prevention testing program where we were only allowed to test Black and trans, Black MSM and Black trans folk. And so we were allowed to test 20% outside of that, but getting that number of Black folks to test was really difficult. It was really hard, especially when it came to doing street outreach, because we didn't have a particular place to go. But what we did have was clients who came in every 3 months for their testing. And so we asked them if they knew any other guys who would be willing to test. And if they did, would they be willing to bring them? If they did, it was an incentivized program, but that the program went for the recruiter and the person who was getting a test. So this was a new person that had to be coming in, someone that was never a part of our testing program before. What this allowed us to, what that exchange gave was the recruiters learned how to explain things like PrEP, PEP, why it's important to get testing in their own way to their peers. So it wasn't a very medicated explanation. It's very important to have that understanding, that flow between your peers, communication at your level and where you are. That's why the peer navigation program is very important. But I also think when we talk about outreach, we have to have people who speak at the same level as the folks that we're trying to get in. So all this to wrap up to say, we need to start diversifying how we do outreach. What is considered to be outreach? Because community is not buying the way that we've been boxing what outreach looks like. I'll say that and hush my mouth.
Thank you, Ray. Anyone else?
I feel that for us to be more successful to work with people that is living with HIV is to meet the client where they're at. We can't force them to take medication. We can't force them to go to the doctor. And as you say, Ray, like in an ideal world, we would like to report labs every 3 months. In an ideal world, right? I'm happy with once a year. Like if I can report that the client went once a year to get tested and they're undetectable and the CD4 is like above 200, I'm happy with those numbers. So I feel it's just about it and call them and explain to them that we are there for them whenever they're ready. I feel that that's something that has been working for us in the past 3 years that I've been working in HIV. Thank you.
Thank you, Alejandra. Anyone else have comments, additional?
Yes, I was looking to raise my hand. This is Alicia Diggs. I'm with the UNC Cfar, North Carolina, Community Engagement Manager. And with that question, what comes to mind is stigmatizing language. Keeping in mind the language that's being used, not to re-traumatize community members with not being updated on some of the language that's used. I could go further, but many of us doing this work understand that. But just, being more with the times with some of the language surrounding HIV, people first language. That means a whole lot to people living with HIV, the communities that we work with, to not re-traumatize them.
Thank you, Alicia. So that will bring us to the next question as we are addressing stigma. So as we addressing stigma and racial disparities, what are some of the methods, approaches, and resources that you use to address it?
I'm gonna make this plug again. NMAC has a beautiful training, Escalate. It is very good, but they also have a sister training called Elevate that is more community focused. So as that's coming out, folks go look it up. They provide a lot of good resources and tools. So just go and look it up. It's excellent.
Thank you, Ray. Any additional thoughts?
Good morning. This is Alistair Burton down in Los Angeles, and I've been listening to a lot of this with fascination and a little bit of depression, because I'm hearing a lot about meeting the client where the client is at, but I'm not hearing much about meeting the client where the client is at and gradually bringing them up to better understanding at the client's own pace. And I know from my experiences with ACTG going back to the 1990s that one of the major things that I believe was a very strong factor in the successes of ACTG was the fact that there was so much emphasis in speaking to the clients and the patients at their own level of understanding medically, and at the same time, both obviously and intentionally, and also somewhat sneakily, introducing better understanding of what was going on with the clients themselves medically, and with what the aims and goals were, the scientific method, why it was important to do things in that way. And that did a significant amount to reduce the negative impacts on stigma on the individuals that were involved, because it armed them with the knowledge that they could use to choose when the stigma was going to be something that was going to disable them, and to choose when the stigma was going to be something like the mountains in the distance that have flash floods that you had to be a little bit careful to avoid, but you didn't have to choose to accept to cause you problems. I think NMAC is trying to work a little bit towards that, but I haven't had that much involvement with them so far. Does any of this make any sense? The other thing that I'm noticing, and I've been sort of quietly in the background because I'm not from the Seattle area, and this meeting is primarily for the Seattle area, but also hopefully for other areas. Like I think I heard Alicia is from North Carolina. So I, like myself, joining in to try to learn what's going on in other areas and see if there are better ways for things to go on. Down here in the Los Angeles area, we are finding that when we try to get community involved, we're reasonably successful in getting community involved when community members are employees working for organizations. But it's an almost impossible challenge to get folk like myself involved who aren't employees of the organizations, but were volunteers. And again, my memories and experiences have been that ACTG thrived because it had volunteers who joined in with a passion, and then that passion was word of mouth passed on to others to join in as volunteers. And my suspicion is, and I'm not trying to put any of the employee community members down, because employee community members are doing a great service to our community, but the employee community members aren't able to bring other community people in as employees. Whereas the volunteer community members were able to bring in other volunteers. Now, COVID has completely messed up with everything in terms of outreach because of the lack of the ability to meet. One of the strengths of community outreach has been, if you can feed people, they will come. And it doesn't have to be anything particularly major or gourmet. The proverbial pizza brings so many people in, and some of those people would come in and stay as volunteers. So I think I'm talking about things that I can't say what is a good solution, but I think they would be helpful if we could find a way back to trying not just to meet people at their level, but also to meet them at their level and then bring them to the point where they could understand things better. COVID has been a disaster for that, because I have not seen any effort to actually help people to understand what's going on with COVID. We've seen all sorts of smoke and mirrors with statistics, but we haven't seen something that actually says that things like the clotting problem was 1 or 2 in a million, literally, across all the vaccines. But it was being hyped as being something that sounded like it was 1 in 10. And that to me did a great disservice with the vaccines. Because people did not understand that it was 1 or 2 in a million. They believed that they were getting good information that was telling them it was 1 in 10. Again, that's not a number that anyone said was 1 in 10, but that's the impression that was given to the layman. And I think our scientific community has done itself a disservice by not finding some way to express the importance of the scientific method, and also that here are the real statistics, not the political statistics. And that's not just the prior administration, that's plumb in the responsibility of the current administration. No, I said to Michael I would play nice, so hopefully I have played nice. But is any of this helping to seed the conversation? I have been seeing some nodding heads, so I will now shut up and let other people join in to either agree or disagree, and hopefully this is a helpful part of the discussion.
The messaging around communicating science is really critical, and I think it can't be overstated, actually.
Thank you for your insightful response. And I think Ray has his hands.
I was just going to say, piggybacking off of what he was saying, is I think there's been a loss of imagination and innovation, new energy for this work. There's been a loss. People have been drained with the way funding is structured and how that boxes the way we work. People have been tired of the systems and how they've been structured or the lack of structure, and how that continues to influence how we do this work. And so I think the point that he was making is that we've lost what it means to be human in this work. And what we're dealing with in this work is human beings. And we're dealing, let's just call it out, we're dealing with sex in this work, people. We're dealing with human beings and sex. And what we have done is taken this work and turned it into something that it is not. We have turned this into a textbook field of work, and that's not what this is. And that's why we're losing. You can sit up there and talk about all the things that we've done. You can say, oh, we're doing this and 90, 90, 90, all you want. But if you let Mr. Dimitri tell the story about what we're doing, there's some things that we're not doing extremely well. And by Mr. Dimitri, I mean our HIV national plan. Let him do a presentation last week and bring up some numbers about Seattle and PrEP. So when you have people in community and community-based organizations who, and in our structured systems, who are constantly bringing up these issues and no one does anything about it. These issues, disparities, needs assessments, findings, all of these things have been outstanding for years. And the action items following have been lacking. So when you're asking why community partners are tired, community members are tired, the people in this workforce are tired, is because nothing has changed. When are you going to get up and start thinking of doing something different? And by you, I mean all of us. It's going to take all of us to change the work. That's what it is. That's why everything has been a plateau or very played out, lame, whack, however you want to call it. That's why. We're stuck. And if we don't get out of this and start doing things differently, we're going to get worse, not stay right where we are. It's going to get worse. Take the urgency, take this break that we've had as an opportunity to get up and do something new, people. That's what we need. I'm sorry to get like this, but we have these I've been doing this work for over 7 years, and we've had these same conversations for years. Community needs assessments. How many do you need to do before you find out what the community needs? That's the purpose. The thing that's missing is the action items following. So let's get to the action items and strategically plan action items. Don't just jump to a solution with no plans. We do that a lot in Washington State. Let's plan step by step. If you don't do well at planning, take a seat back from the planning. But what do you do well at? Come in where you do well. This is not about feelings, people. Our paycheck, if you get paid in this field of work, your paycheck helps you cope with the struggles of this work. We have to work, period. And if you don't want to do it, it's time to exit and let some new folks who are ready to get this stuff done come in. Encourage them. How do you mentor people to come in and take this work and do something different? I have 2 people here that are on cam right now that I've seen be involved in their community and bringing people into this work that I've seen do it. Not just, oh, I'm talking about equity today. You have to be consistent. That's what's missing.
Thank you, Ray.
If I may speak briefly in response to what Ray was just saying and to support him in it, the other opportunity that I see as a missed opportunity so far has been probably because of the unpopularity within the community of the prior administration. I think we should have been, as a community, we should have been emphasizing more that a whole bunch of what we succeeded in doing with getting a vaccine for COVID as quickly as we did, out to the public as quickly as we did, was based on all the work and efforts and research that was done in HIV over the prior decades. And to me, that was a missed opportunity to again meet the client down at, I apologize for using the word down, but in terms of education, it is down at the client's level, and raise the client up as far as the client is ready to be raised at the client's own pace, so that more and more of our community can understand what is going on at the scientific level as well as the human level, and can have more confidence in being able to take a look at their own, as something as simple as looking at their own blood work numbers, and actually say, oh, yes, my CD4 is going up is a good thing. My CD4 is going down is going to happen some of the time, and as long as it comes back up again, that's a good thing. But to be comfortable with that level of information and sharing that level of information with their own peers, so that we actually lay down the trails of breadcrumbs that can encourage, as peers, our own peers, to lay down their own trails of breadcrumbs. And that's why, to me, the whole COVID thing was a wasted opportunity in the respect of, we should have given full credit to all the research and efforts done over the prior decades in HIV that allowed an mRNA vaccine to be developed, tested, established as being safe to hazardous to 1 or 2 people in a million. Yes, that's going to happen with anything, because I think there are more people than 1 in a million that are allergic to aspirin. And that has been a very helpful drug over the decades for all sorts of people, just because people realize that some people just should not take aspirin. For everybody else, they should take it safely. And we educated them to take it safely. And currently with aspirin, I'm seeing more and more studies that are saying, well, it can cause excess bleeding, therefore we shouldn't be prescribing it. But it's causing excess bleeding for how many people? It's certainly not 50% of the population. I'd be astonished if it's more than 5% of the population, if it's used at a reasonable level. but I don't see us actually educating the general population and getting people to be familiar with that and comfortable with it. As Alicia says, some people are allergic to aspirin and some aren't. And those that are allergic to aspirin are as unfortunate as those that are allergic to shrimp. There's nothing that can be done about it, particularly. And those of us that love shrimp feel sorry for the people that are allergic to shrimp, but it's a fact of life. And if we can bring this down more to what I consider the human level, where people are encouraged to understand and be comfortable and enjoy understanding better, we will do our community and our communities, because we're not just one monolithic community. We are a whole bunch of communities with a shared interest in getting rid of HIV. I've mentioned to my colleagues on the Commission on HIV down here that one of my functions in joining the Commission on HIV is to put it out of business. Because the way we put the HIV Commission down here out of business is by getting a cure for HIV that's applicable everywhere. And that's not going to happen in the next weeks or months, and probably not in the next decade. But if we can put more effort into that and less into feeding our politicians, I think we'll do a whole bunch better. And that last part was contentious. Again, I'll shut up. Thank you.
Thank you for your valuable insight and for pointing out that this is all of us' responsibilities, and all of us has to work together to make a difference. Anyone else? Before I pass it to my colleague, Nahom, for the next question.
All right. Yeah, like Rahel said, thank you so much for your passionate conversations and insight, everyone. It's very much appreciated. As for our next couple of questions, it's going to be dealing more with some of the challenges that we've seen in our work. So my first question is, what would you say are the biggest challenges or barriers in your community for people living with HIV today?
Definitely language accessible services. I feel that's the biggest challenge for our clients. The fact that they are not able to make a medical appointment by themselves because there are not interpretation services available, or if they are, they have to like select on the menu the option for interpreter, but it's in English, so they can't do it, and it's very, very difficult. Also, you know, like going to medical appointments, because we have doctors that don't have like late evening, I don't know, like after 6 p.m. medical appointments, or on Saturdays. You know, I feel those are like the biggest challenges, because our clients have like very weird like work hours, and sometimes they just can't go to the doctor at 2 p.m. on a Tuesday, right? And so it's very, very challenging for us and for them.
Yes, thank you, Alejandro.
So what you say single, oh, I have a quick question, you say single.
Any other thoughts?
Representation. Folks want to see a doctor and that looks like them or that they can relate to, and people are not seeing that enough, and it is absolutely contributing to why folks are not engaged in or have gotten out of care. So I think how we diversify, again, staff is very important, and how do we link people to those folks that fit the criteria? Is there a list of providers, specific providers that fit categories that people can go, this is where I would feel comfortable? Do we have that? People have mentioned it for years, but is it available and is it updated?
Thank you, Ray. We have a hand raised.
Yes, this is Alicia. I was actually going to say that as well, so thank you for raising that, Ray. Also, community members are actually spoken to instead of spoken with, there's not a conversation with them. They're not spoken to, and this is just commentary that I hear as a community member and when I speak with my peers, trying to understand why there's a disconnect there, because a lot of times nowadays, community are not seen as human beings, or not spoken to as human beings. There's a complete disconnect there. So it's almost as if, especially when it comes to research, it's like you want my information, you want my participation, but you don't want to include me as a team member. You don't want to include me as a partner. You don't want to communicate with me as a human being. So when that information is not disseminated to community members as human beings on their level, there's a complete disconnect. There's no room for trust. And just like Ray said, when there's not anyone there who looks like them or who speaks the same language, then there's no room for a connection there. And a lot of times our healthcare workers, those who may be a doctor, a nurse, what have you, there's no time for them to come out of their circle of the work that they do to come out in the community. So you have no recollection of what's going on in the community, and you have to depend on another community member to educate you on them. So there's not a relationship there. So in my opinion, this is just Alicia, in my opinion, there's a disconnect because you're in your bubble over here doing your work and you want to include the community, you want to have a part of the community, but you have no relationship. You have no idea what's going on. It's like I can't really go to China. I can go on a vacation, but I can't speak the language. I can't speak the language. I need a book. I need a translator, but I really can't understand because I don't know the language.
Thank you, Alicia. Mr. Wakefield.
I'm a bit challenged by the framework of the question. We have developed care and systems and policies for making sure that there aren't barriers for folks living with HIV. But I'm disturbed by the fact that every day there are still new people living with HIV. And I would have preferred a question that took in a direction for us, that we take a look at why, with the mechanisms to completely eliminate new infection, we are still having new infections. Why we don't link our syphilis campaign. Once upon a time, I could believe it was just funding, but having the STD delinked from HIV prevention doesn't make sense to me. And why we don't take a look at health-seeking behavior and those same barriers that are keeping people from HIV from getting and maintaining themselves in the care might be the same barriers that are keeping people, that could help us figure out to stop new HIV infections. And that should be a priority, I think, for the Cfar. And I know that's not the framework of the question, but that's my response to it.
Thank you. Any final thoughts before we move on? Okay, perfect. So our next question is, what are some of the community engagement failures and setbacks that you've observed in working with partners and stakeholders?
Afterthought inclusion. And I'm sorry, I didn't raise my hand. but it's happened too many times. People get included. Oh, we need to reach out to this community. And then they do all the work the way that they think it should be done. And then they tag on the community that it's supposed to be going towards later. And this is a very big habit in this field of work. And surprisingly, it comes from a lot of people that are seen as the know-it-alls and be-alls of everything. And so when you have people who are decision makers that continue to make these actions, again, it goes back to that point of relationship. If people have seen these actions or have seen themselves be included as an afterthought several times, well, I'll just say this. If somebody said, I'm gonna invite you over to my house for dinner, and all they had was bread, cheese, and water, and it's the second time they done that, how smart would you be to go back? One, without your own little meal or eating before then. People, again, it's that tired, the engagement hasn't been engaging. It's always an afterthought.
Thank you, Ray.
Unless it's white gay men. And then we will quickly add them. I'm sorry, I had to add that, but they will quickly be at the beginning. And so if you look at numbers for PrEP usage or any of these services, who is utilizing all of it? And so you can see where the effort is made when it comes to education, communication, awareness, language access, materials. You can see where the education is pushed. And then you can clearly see which communities are left out as well. So I do think I need to point that out. It's very clear when we lack, but it's very clear when we do well with communication.
Any other thoughts on this question? Okay. Alistair Burton also put in the chat if there are any thoughts on, positives or successful efforts you've all had with partners and stakeholders. I think I saw a hand up just for a second. Okay, if not, we can move on.
Yes, I'm sorry. This is Alicia. I will say personally, the positives that I have seen is the fact that, and I am very open, I am a woman living with HIV 20 years. And because I am open, I am a part of the community. I'm also on this, I am on both sides, the community as well as the professional spectrum. I don't come with my professional hat on. I come as a brother or a sister in the movement. So even though I have some letters behind my name, that doesn't matter. I come as Alicia in every space that I walk into. That also gives me the opportunity to build relationship and trust with whomever I walk into a room with or whomever I have space with. So that's where I have to say I have an advantage, and that's where I have seen success. I have had the opportunity to engage people who I was surprised I was able to engage because of the work that I do. But the response that I received was because of the relationship that we built. because people know that I am open with my status and I wasn't always where I am now, I never changed who I was from the beginning of my diagnosis. I didn't come in with, okay, now I have this education and I have these platforms and I have the big head. I stayed the same and I treat everybody the same. And that gave them the trust that they needed to say, you know what, because I know you, because I know that you work with integrity, I'm able to follow what you're doing. I trust what you're doing. I trust that whatever you're asking me to participate in, that it's something for my good. So that's where I've seen, positive output.
Thank you for sharing your experiences, Alicia. Okay, I think we can move on. Oh, one more hand, Josh.
Hi, thanks. My name is Josh Sherbeck. I was an assistant professor in the Department of Global Health for a while. Now I'm just an affiliate and have moved to the Gates Foundation. But I wanted to thank Ray for bringing up the point of engagement after, or engagement without actual engagement, because my work is using HIV gene sequences to identify transmission patterns in communities. And well, I had a project, or still ongoing project, looking at HIV sequences from King County. As part of molecular HIV surveillance in collaboration with PHSKC. And I guess Ray's point really hits home, because we had wrote the grant and we're doing projects, and then starting hearing about community concerns about the use of this data, potentially without consent, or actually without consent, but potentially with larger concerns in the community about stigma and criminalization. And so my PI and a fantastic PhD student at the time, Dan Tordoff, started reevaluating, and we spoke to Stefan, and we spent a lot of time speaking with Brian, and we've tried really hard to do some actual engagement, but it still was after the process of writing the research proposal and doing a lot of the research. And so I just wanted to, I don't know what else I really want to say here, but other than like, I really hear Ray's comment, and I think it's really important. And I recognize some of the errors that researchers have made from that perspective, because I've made them, and I'm trying to do better. And Brian has been really helpful in this process. At the same time, myself and my team, want to move forward with these types of analyses and research programs. We think it will help the community in some way, whether if it's not short term, it's long term, understanding HIV transmission and stuff. But how we do that, I hope that my process will be fundamentally changed by trying to engage it in a different way. And so anyway, that's all. I just want to say that.
Yeah, thank you for being honest with your experiences, Josh. Any final thoughts on this question? Okay, I'm going to pass it to my colleague Michael for the remainder of the questions.
All right, so which one did we leave off on? I'm doing 2 purple right there.
Yes.
So yeah, I just wanted to make sure, because I was just looking at the one question, thinking about that. So the question is to you all, what are some of the top community priorities that would need the support of further research? What are top community priorities according to what you see? What do you think are the priorities that people need, community needs, that could potentially use additional research? And you can type these in if you wish. You can speak them if you wish. I agree with Alicia. Aging and HIV for all populations. It's the blessing of having treatments that work and having people live longer, is that we're having people that need geriatric care combined with their HIV care for all populations. Mm-hmm. Mm. What are your thoughts? What do you see as a priority for your community or from your viewpoint? Mm-hmm.
If I may vocalize this, all of the things that intersect with HIV or any of the comorbidities should probably be prioritized and not just one or the other. I think it's the reason why we're in this situation again. When we go to these meetings, the question always ends up being, what's 2 to 3 action items? But a person is not dealing with 2 to 3 action items. It's whole person health. That's what they're dealing with. They are a whole person. And so again, back to very many points here, Alejandra, we've taken away the human aspect for the person. They're not humans anymore. They are a component of this. They're this health component. They are this health component. I think it's another reason why a lot of people are having an issue with figuring out how to measure quality of life, because we're looking at a person as a health issue and not the person. We're not even looking at the person. We're looking at the health issue. So if we can get rid of looking at the health issue and whole person health, as people are sitting planning syndemic approach, what does that actually look like? And how is it different from the way that we're doing the work now? So I think the question of what are some, we have that. The community needs assessments that we've all been doing answers those questions. All of the forums that we had about intersectionality and race and gender, it all intersects. It's everything.
Thank you, Ray. Alicia, did you want to say more?
I did. I actually was having a conversation earlier when it came to everything that Ray said. And also something that just really bothers me to no end. I feel like with everyone trying to or working on ending the HIV epidemic, there's such the way that things are done, in Alicia's opinion, this is just Alicia, is such a division amongst all communities because research is focused on MSM, research is focused on transgender, focused on, ages such and such to such and such. And it's like, because of funding, because of, just numbers, because it is just so inhumane, it causes a division amongst all communities. And if you really just look at that, if we step back for just take 5 minutes, 5 single minutes, and just step back and see the humanity in everything, there has been such a division amongst people. When I think back to remembering when there was, AIDS, and it was even before there was the name AIDS. This started before I was a teenager. And I just remember when there was a complete coming together as a whole. It wasn't a separation. Yes, this virus was blamed on gay white men, but there was still a whole coming together as a people. And now there is such a division. There's a division amongst cisgender people, to transgender people and, you know, the LGBTQ plus community. There's so many letters and so much going on, and we're all focused on pronouns and these letters and this and that going on. We have lost so much humanity. And, you know, for me, it's sad and it just breaks my heart that all the work that I know for me personally, I'm trying to do, I'm still hearing, well, my community is not being focused on. Well, what about me? Well, I want to participate in this, but why are they a part of it? At the end of the day, daggone, we are all dealing with HIV. We are all dealing with trying to end the epidemic, trying to live healthy lives, trying to have some peace of mind. But all of this is causing so much division. And I know for me, I'm tired of it, but I'm not going to stop. So I just had to throw in my commentary on that.
Thank you for doing that. Beautifully said. Any other comments? Go ahead, Alistair.
As I've been listening to this, I've been reminded of the fact that I came over to this continent as an immigrant at age 21, and I brought over with me the idea and the somewhat tasteless joke that I don't actually care who gets cured of HIV first. Doesn't matter to me one bit which particular subgroup somebody gets cured of, because once one person is cured, more and more people can. We have, what, 3 to 5 people that have been cured of HIV so far, and they've been cured using techniques that have about a 1 chance in 3 chance of killing them, which means it's not something that's going to be applicable to our entire population, but it does mean that it's been successful so far. So we've a path to go. And the tasteless joke part is that in Britain, we actually would encourage primate research, not just non-human primate research, because we don't actually care if the first people cured are the archbishops. The archbishop being the primate of the religion. And they are highly prosperous people. They are likely to be among the elite. But if they get cured first, just because they're rich, I don't care, because that way it can trickle down to the rest of us, because that is the reality of life. And I get nervous whenever I see insistence, for example, that in a study that was designed for men who have sex with men, there then becomes a requirement to have women in that same study, rather than let's have a parallel study for women, because it makes it much more difficult to do the actual science that we need to do. And unfortunately, a lot of our media stokes those divisions. And I suspect that we allow that stoking to affect us much more than is healthy for us to allow. And again, I don't know a simple solution to this, but to me, it is a problem.
Well, thank you, Ancient One.
Well,
I see your
I'm now
pronouns
resigned
there.
to that fact, and I decided I might as well make it one of my pronouns.
There you go.
Thank you.
So everyone, we have one final question, and I would love everyone to warm up their fingers, because I'm going to ask you all to type in the answer to the question in the chat when I say to do it all together, so we can have a tidal wave of responses to this. Now, hopefully you all like when people are accountable, that they stay accountable to whatever they say they're going to do. What are some of your favorite ways that people can show their accountability to you? And we're going to transfer that for this institution called the Center for AIDS Research. What should be the mechanisms for Cfar's accountability to the community? Think of the ways that you like to see things being accountable, and how do you think this research entity should be accountable to you? How would you like to see that? And I would love you to type your answer in the chat. and then hold on from sending it for through 3 or 4 seconds, and we'll send it all together if we can. So type your answer, how you would like to see things to be accountable. From the Cfar to community. I've just typed my answer. All right, if you have an answer, you can hit the return button and share it all together. If you're still working on it, that's great. And if you have something that you wanted to share with that answer, please feel free to unmute yourself and speak up, or just you can read through there. And if you want to comment on something that you see, I like the answer money. Putting money towards that. Transparency of data. Do what you say you're going to do. Show up as you said you would. Keeping persistent in outreach. I always think that's about money. Too often outreach dies because the money dies, or the money goes away, which is always a shame. Annual reports, someone says. Consistency. Remember humanity first. Accountability for me, bluntly bringing up what we have and haven't done and volunteering that information without someone needing to pull it out of you. Got it. Being okay with critiques and bringing ideas together to move forward. I like that. Let's see, I didn't get to see as far back what we had there. Community engaged in leadership at all levels. Podcasts or brief written updates. Show the data. Cool. Let's see down there. Collaborate as equal partners. I think that's one of the things that's missing. Collaborations sometimes are uneven. I think making everyone an equal partner and making decisions equally that way is a great way that you can level that playing field. Any other ideas of how you would like to see accountability? Okay, well, we're nearing the end of our call, so I'm going to turn this back over to, I don't know exactly whom, Jasmine, Stefan. I don't know if we have any time for the other things that you wanted to have planned, but I think we can at least wrap up what we've accomplished today, which seems to be a lot.
Sure. Thanks for that. Then thanks everyone for your participation so far. We do have a couple of other components, so I guess I wanted to do a time check with folks. I know the time was reduced to 2 hours. If you are able and interested in staying on to hear about how the Cfar is planning to mobilize going forward and some of the initiatives that are being proposed, please feel free to stay on. If not, we can solicit that perspective via email or other ways. But I have to acknowledge that though we went over time on this section of the agenda, this was hugely beneficial to the process. And so I appreciate everyone for engaging, taking their time in this.
Yeah, I agree. It was great. And it was just Connie and I giving the overview. And I don't know if Jasmine, you just want to share that last slide of the mission and the structures, and we can end with that. I do want to respect people's time. We said 10 o'clock and I'm one of the ones who has to leave, but we could just, I think Connie, you were going to speak about that and then show the structure.
Yeah. Maybe go back to the mission statement. So we're still polishing this, but I feel like we're trying to use this every 5 years. Cfar has to each Cfar has to put in a new kind of plan for the next 5 years as part of the funding, and it is really an incredible opportunity to take stock and say, well, how do we remain relevant? How do we increase impact? So we're trying to really make community engagement a more central part of what we do. I think that it has happened. I'm sure we can do it better, But basically, I think that's here we're writing the mission statement to catalyze and support innovative, interdisciplinary, and community engaged research from basic clinical, excuse me, and social behavioral science to implementation studies with demonstrated impact on the global HIV epidemic and nurture, it's a long sentence, nurture the next generation of HIV researchers and leaders with an emphasis on early career investigators and those currently underrepresented in the field due to systemic oppression. Then the next part is the cross-cutting themes about trying to do more, do better, the fostering of an inclusive collaborative research environment rooted in anti-racist and decolonizing principles. And that applies both domestically and globally. To cultivate equitable and mutually beneficial community partnerships that inform Cfar research priorities and facilitate implementation and impact. And then I just really at this, as we're really heading into the final few laps to put this together, our scientific themes are anchored in translation of discoveries into delivery and impact in all aspects of HIV research. Share and adapt lessons. It's great that Seattle King County reached 95, 95, 95 and has introduced low barrier care, but how can that be adapted elsewhere in Washington and the Pacific Northwest? An increased focus on prevention, both prevention of HIV with PrEP and behavioral interventions, as well as prevention of HIV-associated comorbidities. And then lastly, I think this is something we need to, continue to chew on and would appreciate community feedback is how do we come out of COVID to the extent we're partially out of it and do better at providing care in a user-centered way, including but not limited to taking these new tools of injectable antiretrovirals for prevention and treatment. And how do we do that so that people who want it can benefit from it? So just next slide real quickly. You can advance that, Jasmine, thanks. So really, and again, if you want to see more, we can share more. We're actively working on developing these. We tried to simplify the number of cores, make it easier for people to see kind of what our real, sorry, go back. Go back. No, you're going forward. There you go. So we have the Office of Community Engagement as part of the admin core. We have a developmental core that really supports awards to the investigators, and we're adding a community award, and we'll hopefully learn from that first effort to do that. And maybe as we get closer to doing that, we can get input. We have a data science and methods core that supports the research in all these other cores, and those cores are the clinical core, which has both domestic and international repositories, implementation science, behavioral interventions, prevention of HIV-associated cancers and non-communicable diseases. We've combined the laboratory cores into one, which we're calling the retrovirology, immunology, and cure core. We hope that'll make it easier for people to kind of navigate through the complex Cfar structure. And then two new scientific working groups we're really hoping they will catalyze more emphasis on health equity and substance abuse and HIV research. So if you want to learn more about any of these areas, please, do reach out to us. I mean, I feel like this is truly, clearly just a beginning of this conversation, and we want to be more outward looking and engage in a more consistent way. I think I've been incredibly impressed by and appreciative of the comments people have made, and we'll try to figure out when people feel comfortable doing this in person. I feel like that would be one next step, maybe summer, early fall, and just thank you. Thank you for your interest. Thank you for your work. Thank you for your engagement. I think we're all kind of coming back out of COVID, trying to look at our work and try to think about what we hopefully have learned from some things we've learned from COVID, and really think about how to do it better and to have greater impact. So I hope you'll continue to walk this walk with us. Thank you. Stefan, do you want to make any comments?
Yeah, I just wanted to, I think we're at the, the conclusion. So I just wanted to thank everyone again for taking the opportunity to engage with us. This has been an amazing conversation for so many reasons, getting to see some familiar faces via Zoom. I'm looking forward to seeing faces in person also soon. And we will follow up with everyone here regarding next steps. We will also try to get a transcript out about this because I know there were quite a few links and resources that were put into the chat so that everyone can have access to that information. So if you have any questions, feel free to reach out to us. And again, thank you all. I hope you have an amazing day and a great rest of your week.
Yes, we're going to make the recording and transcript available online. Thank you for asking about that, Alistair. And email the link out to folks who've registered or otherwise RSVP.
Thank you. The other thing I'm looking for, and I'm not finding for some reason, is the ability to save the chat myself. I thought I used to know how to do that, and I'm not finding it.
That might be a Zoom setting restriction. So what we'll send out will give you the ability to access this chat document. I wish I could see it from your perspective, but it's hard through my host lens.
Okay, thank you.
Thank you.
And,
appreciate it.
Thank you. Thank you from far away. Bye for now.
Thank you, Jasmine, for your incredible work on this.
Thank you all for coming through in a clutch.
Coordinator, manager
It was
extraordinary.
like, pull the rabbit out the hat. Just call me
Perfect
Jazz
intro.
Hands. Like,
this is really great. Really
now you don't
great.
see it. Now you do. No, thank you all.
Excellent work.
CCG.
Good, Jasmine.
Life. You guys pulled through your peeps. Thanks. No, it was such, oh my gosh, such.
Please place your Grubhub order for an amazing lunch.
I'm looking forward to having more of these in person. I think
Hallelujah.
the passionate perspective is, you know, you feel it differently in person. So
Yeah.
Love that.
I can only imagine because I'm feeling it on Zoom. So I can only imagine in person.
yeah.
Yeah.
I mean, I've known Ray for years, you know, Alicia, some of these other, yes, Wakefield, like, so it's, I'm absolutely looking forward to doing this in person.
Yeah.
And I definitely think we need to do a gathering, dance contest, some fun games.
Now I got to train my CCG committee members so that we can show up and show off.
Yeah, for sure. I know. I haven't brought up the whole Jeopardy concept, but that was like, that did occur, came back to me the other month. I was like driving and I was like, I remember she was tossing that out there. Yeah.
Well,
Yeah,
thank you
thanks
so
too
much,
for rolling
everyone.
through the, yeah, you too.
Thanks, Rahel.
Thanks, Rahel.
I will, you know what? I'm gonna pack my kids' lunch, take a breath, and then work on getting the follow-up online and then directly to email to folks. And then I'll also make sure, because there are different versions of the slides. So I will go back and kind of adjust Connie's last version to make sure they incorporated some other edits from last night. So just to kind of confirm those
And make
details
sure.
as well. Because I was like, wait, no, I did change that. And yeah.
And the org chart, I'm sorry I didn't respond yesterday. That,
no, it's okay.
That needs to be updated. That comment about where we have substance abuse, that's wrong.
Yeah.
That's just something that Connie had put in it's never been that.
Yeah, I think that was like a copy. Yeah, I'll I'm gonna just
And
kind of
take care of you. Please take care of you. I know you've got your kids to feed. I don't want to be that person that's like, make sure you take care of yourself. But like,
no, I'm
it's an
sorry.
encouragement thing.
I'm always oversharing too. Like you guys have like my life is like a walk-in closet. But no, I will. Thank you. You as well, by the way. Thank you. Grateful for you. See you all soon.
Thank you.
Okay. Bye.
Take care.
This was awesome, Stefan.
It was.
So, man, I'm like, I'm just listening to people. I'm so moved. I'm like, I need books. I need audiobooks. I need shows. This is just, I mean, you've always known this, but just the wealth.
We used to have some really, really powerful conversations in person years ago. So I'm looking forward to re-engaging that energy.
Yeah. Woo. Blessed too, because I was reflecting. Obviously, I'm new to Cfar, but I was just reflecting on the history, the work that this community has done. I mean, just to have this conversation too, just adds perspective to all that you have up here when I'm listening to conversations with Cfar leadership. And yeah, I'll let you go now. But thank you.
No worries. Thank you. I'm about to go finish packing to catch my flight. But yes.
Where are you going now? I can't keep track.
Me either. Houston for the rest of the week, and then DC all of next week.
Okay. Got it. All right. Well, safe travels.
Thank you.
I'll
Take
talk
care.
to you soon. You too. Bye.
Bye-bye.